Hello, everybody, and thank you very much for joining us again today. Today we have the pleasure of having Professor Riccardo Rossetti from Italy, and he's the head of the European Society for the Surgery of the Esophagus. And Dr. Rossetti, can you hear me?
Yes, I hear you very well, and thank you for inviting me.
Thank you very much for accepting our invitation, and I understand that they haven't seen your kids now for a whole few months, and your grandkids, right?
Yeah, because yesterday it was my birthday and the lockdown ended on June the 3rd in Italy. And since they live in another region, they were allowed to move freely and join me. So I was very happy.
So thank you very much for taking the time, and really appreciate you being with us. And please, you have the podium. Please go ahead and start sharing your screen.
Okay, so thank you for having selected this topic, which is a very, very nice topic and sometimes controversial. Let me start my PowerPoint presentation. So I think we can discuss with some slides. Do you see my screen?
Not yet. Did you share the screen? You have to.
I did, but
after you select the PowerPoint, you need to push share. There's a another button to push.
Yeah, I did it. I try again. Just a second. Let's see. Do you see something?
We don't. No.
Don't. Okay. Just a second. Let me go back.
So the PowerPoint is already open.
Yeah.
And you push on the green share screen.
Yeah, I did it.
Okay, and it shows the window, right?
Yeah.
You chose the window and then share.
Let me see if there's anything I can do it. I tried to close and join again, huh?
You join the meeting?
Yeah.
I really don't think this is the issue, Dr. Rossetti. So maybe can I, because there is another button to say after you share the screen, you choose the window, you choose basic and you choose the window, and then there is a yellow share.
Yeah, I've seen it. Share screen.
Yeah, but after the share screen, you choose the window, and then there is a blue share. So you have to. Now we do it. Excellent.
Okay.
Now we do it. Okay.
Okay, great.
Thank you. This is great. Thank you.
Okay, we finally did it.
Yeah.
Okay. So just a few details on the basis of treatment of the Zenker diverticulum. We all know that is a sac-like outpouching of the mucosa and submucosa through the Killian's triangle, which is this posterior area of muscular weakness between the transverse fibers of the cricopharyngeal muscle and the oblique fibers of the lower inferior constrictor of the pharynx. And physiopathology said and showed us that an impaired function of the upper esophageal sphincter, normally a lack of opening of the sphincter in response to the tongue movements that push backwards the tongue to initiate the bolus transmission, and this causes a high intrapharyngeal pressure, a high intrabolus pressure, and this theory was promoted by Cook many years ago. And this causes the pouch formation that swallow after swallow tends to be to get bigger and to accommodate space for food or other materials that stays there. And normally the standing position of the um, um, man during meals cause this increase of dimension of the pouch. So what is important to be understood in the treatment, that if there is an altered upper esophageal sphincter relaxation, we need to treat the muscle. We need to treat this problem, because otherwise, with the high intrapharyngeal intrabolus pressure, we will have the increase of diverticular sac formation. So we need to face two problems. The first problem is the origin of this disease, which is the muscle malfunction. So we need to do a myotomy. And second, we need to treat the sac. Uh, and this depends a lot on the dimension of the sac. So there is an historical evolution in treatment from the first disease report and definition. We had at the end of the 19th century the first surgical diverticulectomy, but diverticulectomy don't treat the disease per se, just treat the sacs, which will recur if we don't treat the motor disorder. At the beginning of the 20th century, we had the first esophago-diverticulotomy through a rigid endoscope just made with scissor. In the second half of the 20th century, we had the first diverticulotomy using the bouvis, always through the rigid endoscope. Then, from the very late period of the 20th century, other means of diverticulotomy were made. But is in 1993, and thanks to Jean-Marie Collard from Brussels, that there was a sharing between minimally invasive surgery and the first use of endoscopic linear staplers and this kind of disease. Normally, the clinical presentation of Zenker have progressive dysphagia, regurgitation, and very frequently rumination. The patient has a chronic cough. They might have chronic aspiration, halitosis due to the residual food impacted in the diverticular sac, needs of very frequent throat cleaning, and also they can retain medication taken for other reasons. So many medication taken cannot be effective since they are not absorbed. Aspiration can be oligosymptomatic, but can be a very severe disease. They normally occur during nighttime when due to the supine position of the patient while lying in bed for nighttime, the diverticular sac try to void within the airway and aspirate. And those are the typical picture of chronic repeated pulmonitis, pneumonia, and with long-standing fibrosis due to the recurrent pneumonia. The diagnostic workup normally is based on barium swallow, and very frequently CNA radiography can show very well in the lateral aspect the pouch and the swallowing mechanism. Um, Sometimes, but those are not very well-defined, esophageal manometry can reveal an underlying motor disorder such as the hypertensive upper esophageal sphincter, but manometry is very difficult to be done. Normally, the probe should be placed with endoscopy. So this is not very often executed as a diagnostic instrument. As I say, the fluoroscopy is the mainstay, and you see in this picture, in this lateral picture, this contrast with who depict a level in the diverticular pouch, which is not voiding into the esophageal lumen. Endoscopy is also very important. On the left, you can see very well the septum, which is the posterior esophageal wall that separates anteriorly the esophageal lumen and posteriorly the diverticular pouch. And in the right image, you can see the endoscopy. Very cautiously withdrawing the instrument. You see here the septum and the diverticular pouch. Why it's important to look in the diverticular pouch? Because extremely rarely, really extremely rarely, but chronic inflammation of this squamous epithelium can also develop cancer on the diverticular pouch. So it's better if you can to have a clear endoscopic vision. So the mainstay of whatever treatment we choose is the section of the muscular fibers of the upper esophageal sphincter. We can do it surgically, and we can do simple myotomy as we do with to treat the simple hypertension of the upper esophageal sphincter with no diverticulum, as we see in some neurological disorders. We can do myotomy and diverticulopexy if the diverticular pouch is small, or we can do myotomy and diverticulectomy if the diverticular pouch is large. And we can do an endoscopic treatment with two options, a rigid option, so the staple endoscopic diverticulostomy. Other means like simple septotomy with CO2, ultrasound, or electrocautery are not very much performed in this moment, since if you can place a diverticuloscope, it's safer to place a stapler, or you can do it in flexible endoscopy with either the septotomy, so the same we are performing with the rigid endoscope, with some different devices like needle knife, a hook knife, or APC coagulation. Or in more recent time, we can do the Z poem or the POES, which is the limited tunnelization of the mucosa, submucosa, and the performance of the simple myotomy. Uh, which are the principles that guide to the treatment? Of course, in the institutes where all the possibility are available. Age and general condition of the patients are very much determinant. Feasibility of general anesthesia, we have spoken of elderly patients. Also, previous surgery in the neck, cervical spine problems. If we need to place a rigid diverticuloscope, we need to have a good hyperextension of the cervical spine. The patient has to have a very good mouth opening, and the shape of the teeth is also very important. And more, the shape and the size of the diverticular pouch. Why shape and size? Size because we need to do at least an almost 3 centimeter long myotomy on the muscle in order to treat completely the cricopharyngeal muscle and the upper muscle of the esophagus. So we need to have at least pouch at least 3 centimeter long, and mainly if it's longitudinal instead of a very wide pouch, this will have a better result because we will create a single common cavity. As for surgical treatment, and I say normally we do a left cervicotomy over the anterior border of the sternocleidomastoid muscle. We push up the thyroid gland, cutting the homoideus muscle and the middle thyroid vessels. We dissect out the pharyngoesophageal area, dissecting very cautiously the diverticular pouch, which is normally lying posteriorly to the esophageal wall. And then if the pouch is very small, we can suture the pouch. So just doing the diverticulopexy by suturing the pouch to the posterior pharyngeal wall, and doing downwards the myotomy, normally with scissors, or if the pouch is wide enough, we can resect the pouch either with a TA or with an endo-GIA stapler in order to treat the pouch and doing the myotomy below the, the pouch. We all know that surgery has some complication. Mediastinitis that can occur if we have performed the diverticulectomy, and even with the staple line can leak, and leaks go downwards toward the mediastinum, as you can see in this image. we can have recurrent laryngeal nerve palsy with, fortunately, monolateral vocal cord palsy. So that can be, and of course also hemorrhage, hematoma, or pneumomediastinum. So those can be sometimes very important complications. What about the rigid diverticulostomy? First of all, we need to have, as I said, the patient in general anesthesia, hyperextended cervical spine, and very good mouth opening. We place the Verda diverticular scope, which is, and I will show you better in the movie that will go on in a few seconds. But just to explain it now, with the two valves that enter, the superior one within the esophageal lumen, the anterior esophageal wall, the inferior one in the posterior lumen of the diverticular pouch, and this will expose the septum, so the posterior esophageal wall, very, very nicely. We use to place two-stay suture, and this is a maneuver that we have started a few years after having started this technique to overcome problems such as incomplete section of the septum. And we are convinced that placing two stay suture at the opposite side of the septum and applying a delicate traction on the septum can ease very much the performance of the septotomy. Then we go in with the stapler and we cut the septum between the esophagus and the diverticulum. It is of the utmost importance to use the very, very first device that was invented, the first stapling gun that was invented for minimally invasive surgery. This is the Endo-GIA. At the time, the company was Auto Suture before passing to Tyco and then becoming Covidian and then becoming Medtronic. Why it's important to use this gun? Because it's the only gun where you can remove the anvil of the stapler that normally has a long shield after the upper limit of the blade coming. But if you leave 1 centimeter, which is almost this area there, this 1 centimeter will not allow the blade to cut through all the length of the septum. And so a residual pouch can stay at this level. And this is the practical example. This is the table instrument, the diverticular scope with the two valves. There are two screws. One screw is moving here. You see that the opening of the back parts is increasing, and the other one is moving in this at the tip of the instrument. So like a crocodile mouth, it can be placed. This is the most delicate phase. I had the luck of having a very nice friend of mine, an otolaryngologist from Padua, Surendra Narne, who did work with our group for all esophageal stuff. And he always helped us in the upper esophageal surgery. And by placing very cautiously this device within the esophageal lumen, we can intubate both the esophagus and the diverticulum. So the instrument is stabilized over the thorax of the patient, and then we start to open the two screws in order to increase the space. And this is the septum. Posterior wall, it's the diverticulum, and anteriorly the esophageal lumen. This is the endostitch that, as I told you, we believe of the utmost importance to do an effective operation, and the two-stage suture are placed on the two sides. This is the anvil, which I said you should be removed. This is the original anvil, and this is the modified anvil. You can just cut the upper part up to the level where the blade will arrive. So you can see here that the blade will cut up to this level, and we don't have the centimeter longer device. Now the instrument is placed in the mouth, and it's placed through the scope. The septum is initially cut, and here is almost a 3 centimeter long myotomy. But you have seen that I have pulled back on the two-stage suture, so there is a sliding of the posterior esophageal wall along the diverticular pouch, and we are allowed to place the second cartridge. Sorry. A second cartridge, and you see that the pouch is almost all gone, just a few touch with the electrocautery to complete. And now, as we cut the two-stage suture that were at this level, we have a complete opening of the diverticular pouch. You see, there is nothing residual at that stage, so we will have a common cavity, an extended megapharynx, let's say, but anyhow, a common cavity that will not allow food to stay and impact there. So pre-treatment, we have this septum, anteriorly the esophagus, posteriorly the diverticulum. Post-treatment, we have a common cavity, as you see there. We normally ask for X-rays also during the follow-up, but you should make the patient aware that probably the radiologist will say, oh, there is a diverticulum, because he sees the megapharynx there, which is not a recurrent diverticulum, but is a dilation of the upper cervical esophagus. So normally postoperative barium or gastrographin swallow is performed on day 1, and afterward the patient can be discharged eating a very smooth diet, a pureed diet, just on immediately on the very early postoperative phase. Which are the complications? Dental injury. There should be some esophageal mucosal tears, aspiration pneumonia, while fistula or perforation as well as bleeding is extremely rare. What determines the failure? The failure can be previewed at the beginning by judging the opening of the mouth of the patient. We use the same Malampati evaluation that the anesthesiologists use for intubation. And of course, Malampati 4, it's rather difficult to intubate and rather difficult to intubate with the diverticular scope. The best are patients without the superior dental arcade because they can accommodate very well the instrument with a wide opening and with a good cervical spine hyperextension. So the first reason of failure is intraoperative. If you cannot place regularly the instrument, you have to switch to another technique, either surgical or flexible. And incomplete septotomy that I can tell you from the moment we could use, we did apply the trick of placing 2 endostitch, was not anymore a problem. This is the case of an incomplete septotomy. You see here a long residual pouch in the inferior part of the diverticular sac. And this, as I told you, can be observed also if you use a different kind of stapler where you have not performed this modification on the device. And the endostitch trick that you see here on the right with 1 and 2 stay suture at the lateral border will allow you to pull up the septum, elongate the and the posterior esophageal wall, and allow a longer section with the staplers. We did publish some times ago some observation in our series without the endostitch or with the endostitch, and both at the 6 month that at the long-term follow-up, we had a better performance with higher number of asymptomatic patients as compared to the series performed without the endostitch. So we believe that this counter traction and the deriving tissue extension provides a complete section. Different thing is the flexible treatment. After the endoscopists have started to do the poem for achalasia, and I would like just to remember you that by doing the myotomy through poem for achalasia, the endoscopist does a small mucosal incision, enter with the endoscope in the submucosal space, create a tunnel between the submucosa and the muscular layers, and then with a J hook, they cut the muscle. So at the very beginning, the flexible treatment was just the section of the septum, and this was a very limited procedure because it was because the length, the depth of the diverticular pouch was the determinant of the success of this procedure. So it was not indicated for diverticula smaller than 3 centimeters in length, so for pouch less than 3 centimeters. But applying this technique to the Zenker, the endoscopists have made a very nice trick. So at this moment, they made a longitudinal opening along the septum, and then they create a double tunnel in the submucosa of the esophagus and in the submucosa of the diverticular pouch, just leaving only the muscular fibers at this level. So they go down with the instrument that is made with a plastic cap on the tip of the fibroscope. And going down there, they can selectively cut the muscle by and leave absolutely safe both the mucosa in both sides of the esophagus and the diverticulum. And then at the end, going back to the when they have finished downwards the myotomy for all the length that they deem it necessary, they can withdraw the endoscope and at this level close the incision on the mucosa with the placing of some clips, and this overcome the problem of a small pouch. So the advantage of this endoscopic septotomy is that this tunneling technique is beneficial with smaller diverticulum, which is the big challenge for this type of treatment. And you see here the endoscope that goes down through this small incision, just highlighting just the muscular fibers to be cut. There is a recent meta-analysis collecting almost 7,000 patients from a lot of studies, but I can tell you that the quality of all these studies is not super because first of all, there are those are all retrospective series. There is no randomized studies, and the follow-up measures, the follow-up is not very clear for all these studies. Anyhow, the success rate that you see, it's different in different techniques. We range from around complete success rate for surgery to less satisfactory, so from 95% to 70%, and also in the endoscopic treatment, both with rigid and to with flexible, there are differences. So those are not very precise study, but in all the clinical evaluation, they were positive for endoscopic treatment, both for days to oral intake, hospital stay, and also for mortality and morbidity. Recurrence rate, as I told you, probably was better for open surgery at the beginning, but with some tricks, such the tricks that I show you, so to cut the anvil of the stapler and to place two stay suture comes very, very good also for in terms of recurrence. And complication rates is favorable to endoscopic treatment, and mortality and morbidity, overall morbidity and mortality also. We did also a review of stapling versus Z-point, and both procedures seem to be safe with low complication rate. Technical feasibility is higher for the flexible treatment in the Z-point because there are less difficulty in the insertion of the laryngosuspensor compared to the rigid instrument. And failures in rigid technique is mainly because of a difficult positioning of the diverticuloscope. Probably the endoscopic techniques need some device like the disposable crocodile hook device that they place very similar to our laryngosuspensor to stabilize the septum, mainly if the patient is done under conscious sedation. Probably general anesthesia is better also for flexible to have a more stable operative field. Our experience is ranging for 186 patients over the last years. We did the transoral rigid diverticulostomy as first choice in 175 patients, 154 as first-line treatment, 21 for recurrent after a previous treatment. We did the incision in flexible endoscopy in 11 patients. Dysphagia and regurgitation were the most common symptoms that were lasting about 2 years in mean. The medium size of the pouch was 3.5 centimeter, but I operated on a pouch that was containing 500 cc of liquid, and at the preoperative CAT scan, the pouch was almost touching the upper part of the aortic arch, so a very big and wide diverticulum, and the patient went well with 5 subsequent application of the cartridges. Median operative time is 25 minutes, very quick if the patient is very well relaxed with good hyperextension of the head, because once you have placed the operation is just placing the diverticuloscope, nothing more. The section is absolutely rapid. We had to convert to open surgery 14 patients, and this is our series. And reason for conversion was impossibility to have a good placement um, of the diverticuloscope. So all the patients need to have a very detailed, informed consent before the procedure. We had in 2 cases mucosal perforation that we detected intraoperatively, and we treated just applying 2 clips like the clips normally used in laparoscopy without needing of suture and without further need of treatment, and pouch bleeding in 1 case. Oral feeding almost if surgery is the first one in the morning, you can do the gastrographic swallow early afternoon, and at the night the patient can start to be fed, otherwise the following days. And we have had very few complications in our series. We care a lot for the follow-up, so all the patients are followed with barium swallow, and we had 6 patients with persistent symptoms and persistent diverticular pouch. 4 of them were treated with transoral diverticuloesophagostomy, and 2 with open conventional surgery. 8 patients were asymptomatic with a persistent pouch detected radiologically. But I would like to outline that all these patients were before placing of the stay suture on the septum. And we had very good clinical results at follow-up. At long-term follow-up, you see 91% of patients are asymptomatic at the long-term follow-up. And this is, I think, the best we can expect from this treatment. So thank you for this attention, and I would be pleased to answer your question.
Thank you very much, Professor. Very nice lecture. So do you do the flexible technique, or you don't do it yourself? You send it to the gastroenterologist?
No, I have a very good endoscopist who was specialized in treatment of achalasia that is doing this. I'm not doing flexible endoscopy.
All right, and let's say, I mean, like what when you see the patients, I mean, what patients end up, like how do you decide which patient goes to for open surgery, for rigid versus for flexible?
First of all, I always try flexible, because even at office evaluation with the patient which is not under anesthesia, you cannot judge if the neck mobility is good enough and the opening of the mouth is good enough. So in my experience, only the length of the pouch is determinant, open or endoscopic. So if the pouch is lower than less than 2 centimeters deep, we always go either to a flexible Z-poem or to an open surgery. If the patient has a bigger than 2.5 centimeter in length pouch, we always try the endoscopic, the rigid endoscopic technique, um, and but the patient is prepared, and he knows that if we cannot place the diverticuloscope, we switch to open surgery.
All right. Just a few questions on the chat line. There's one question about if the can you mix the diagnosis of Zenker's on MRI of the neck?
Normally, we don't. Normally, the diagnosis is with the traditional radiology with the barium swallow.
And another question is like, what's I mean, how do you can you put a number on the risk of having perforation after a rigid approach?
As I told you, perforation in my series are 2 cases over 180 almost patients, so very, very, very little, and you normally see it during the procedure, because and if the diagnosis is intraoperative, treatment is possible. Just placing a single clip, it always happens at the very end, at the distal end of the perforation, of the placement of the stapler. So normally it's easily treatable. And if the perforation should be big, this was not my case. In both my case was couple of millimeters. If the perforation is big enough, you can always open up the neck and treat the perforation open.
So in your experience, you should be able to identify it during the surgery rather than on the post-surgical study like a barium swallow.
We had just one patient who developed fever. There was not a leak of contrast at the CAT scan with oral contrast, but there were some air bubble in the upper mediastinum, and is the only patient who developed this complication postoperatively. Probably it was due to caustic injury made with the hook at the end of the procedure, and it was a delayed perforation. But in this patient, we could do an endoscopy, placed a couple of clips, antibiotics. He didn't need any open drain or anything else than this. And this is the only complication, serious postoperative complication we had.
Another question, can you use coplation device, like something like maybe harmonic knife or something like that, just to cut and seal the tissue rather than having
probably you can, but I think that the advantage of having when you cut the septum, it's an old story. You can do it with the electrocautery. It has been done with laser. It has been done with any means. And in this case, you rely on the spontaneous adhesion between the diverticular pouch and the posterior wall of the esophagus to have a tight to avoid leaks of the cut you have made. If you can place a staple, you are sure to have a good fixation of the two parts with a cut in between of the staple line, so you are more a little bit safer, even if there was not very different results reported with the very old endoscopic septotomy and stapled septotomy.
Another question, do you see any neuromuscular motility dysfunction in the megapharynx after the surgery? Any issues with that?
We didn't investigate with manometry, but clinically the results were very good, and there were no difficulties, no abnormalities revealed by the postoperative X-rays, also with video cinematography.
Question about any relationship between Parkinson's disease and motility and the formation of Zenkers.
We believe that in neurological disorder may cause more hypertension of the sphincter without Zenker, or with very, very small Zenker, instead of a real Zenker due to the hypercontraction of the sphincter. And I think that those fragile neurological patients maybe could need to be operated on, as we do sometimes, in local anesthesia with an opera approach, because both the rigid and the flexible might benefit from a general anesthesia. And sometimes in very old, frail patients, you don't want to submit them to general anesthesia.
One last question. Talk about the stay suture, and like how do you get to pull them laterally, like towards each side? I mean, because I think that
no, you don't pull laterally. You just pull cranially, and this allows you to let's say elongate the anterior wall of the diverticular pouch. As you release tension, they go down, and it's very nice. I always compare the posterior wall of the diverticular pouch to the tip of a snow ski after having made the curved tip of the snow ski is the posterior part of the diverticular pouch, and at the end of the tip of the snow ski, you will find the esophageal lumen. I don't know if you understand what I mean, but really pulling everything towards you elongates make a slippage of the anterior diverticular wall. You cut and then you release and it goes down. So it makes like the tip of a ski, of the snow ski.
Sure. Great. Well, thank you very much, Professor Rosati. Really very nice talk. We really enjoyed it. And everybody has been complimenting this session. Thank you again. Thank you for being with us.
And thanks for inviting me. And my best to all of you. Stay safe. You didn't have the problems we had here with the COVID, but I wonder maybe you have some problem too. So stay safe and say hello to my friend Arturo.
Thank you very much. So thank you, and we'll come to the end of the session. Tomorrow, Rick Nelson is going to, from Indiana, is going to talk about management of spontaneous CSF leak. So please join us. I'm going to leave you with a rotating slides of the upcoming session for the rest of the week. Thank you again, and hopefully we'll see you tomorrow, same time. Thank you.